So I find out that my odds is very bad. You said 10% take it to the finish line, and I have started 2 companies, so I'm in a very bad bad odds for me. Okay, I have a background as a endovascular surgeon, and I have been gifted to do better treatment for ruptured aneurysm. We did it first more than 25 years in Örebro, where I had my practice. And we wanted to improve this by using local anesthesia. And we looked for a need for a closer method that was less invasive than traditional surgical exposure and suture of the artery. And I was lucky. 25 years ago, I was here and visit and work together with you, Ted, and Wenke and Ted. And thank you coming back, inviting me back 25 years later and see what did you give from this baby? What did it become? You learned us the fascia seal, and we implemented it, and it was thought to be for ruptured aneurysm, but the outcome stunned us. So we found, well, let's do it on all comers. So every patient that needed a large bore was treated with the fascia suture, the open fascia suture technique, and whatever the size of the artery or if the groans were hostile, we didn't take them away. The problem in these cases was to get inserted an introducer. If we got an introducer in, we could use the fascia suture. And it was also a good way to push the envelope. For the worst case scenario was a traditional cut down. At that time, that was the golden standard. But there is always a but, and there was a learning curve. You need to know where the fascia plane is. If you go through it, then you destroy the fascia and you cannot get the effect, and how you place the sutures matters also. And we came up with results on another publication around 90% were data, but in experience and from a randomized trial we ran ourselves, we could see that a 96% technical success. And the complications, they occurred immediately, and that was good. You could take care of them. And we saw in other publications also no real significant relation to access hole, no venous complications, and the low pseudoaneurysm frequency. So now, how could we take this open access closer to another level in a percutaneous device? That was the challenge, to capture the basic technology. Make it independent if you are surgical trained or not, easy to use, of course, and reduce operation variation, because some of us are cowboys. It's said we are instructed to do it like this, but one of us wants to do it like on the right, go to the left side. But we wanted to reduce that operation variation and preserve the versatility that this technique offered. And we also knew that we have to develop a product, not a me-too product. There are too many products on the market. To succeed, we have to disrupt the market, the traditional thinking of how to close an access hole and take the leader position. So this is how it works. You insert, you deploy 4 anchors below the fascia. This is from a bench model. And then you tighten, they are connected to sutures. You tighten the sutures, and then the fascia, or as you see, this synthetic membrane comes together, and you bounce tissue. So as it looks in a cadaver. You see the bounce fascia. You can see sutures having penetrated the fascia. And we have a pressurized model that we have used. So we have a good if there is leakage or not. But it's not just about fascia bouncing. And I have to say, it took me 20 years to understand that there was a secret sauce, because the fascia is curved. So it adapts to the sartorius muscle on the lateral side and other muscles on the medial side. And this is, I put in a steel wire when I dissected free the fascia, and that was the curvature. You see on the medial side that it curves down. And this is the fantastic thing, because they are firm, the outer parts are very stable where they are, and when you shorten the fascia by grabbing it and putting it together, then it's just mathematics, geometry. It has to go down. There will be a pressure down, and that should get, the fascia is already close, 1.52 millimeter from the artery wall, and then you get this push down. So we did the first in human in Paraguay, 13 grown, 13 patients, and access was from 14 to 19 French OD. We had 100% technical success. 8 immediately, no manual compression at all. 1 within 1 minute, 1 within 3 minutes, 1 within 5 minutes, and the 2 rest had more than 5 minutes manual compression. When they were all done. At follow-up, no, with CT and ultrasound, no hematomas, no exercise stenosis, 2 pseudoaneurysms not indicated for treatment, no adverse events at all. So here's the device, the Arterica device, and I go through it on a top-level plane. So it's one part that contains the positioning system, and the other part contains the delivery system. Starting with the positioning system, it has a foot that is seated against the inside of the artery's front wall. And that is the reference point to get the handle, the delivery system in correct position above the fascia. And it also contains a balloon that is automatically inflated and stops the peri-procedural bleeding. That could be really irritating, and taking down that is a big advance. By pressing a button, a spring-loaded system implant 4 anchors through the fascia outside the artery, and then you tension the suture with a defined force that the system delivers. And when the device is pulled out, the sutures are automatically locked by a metal structure, so you don't have to do any knots or so on. And what impact will this have? Yeah, the procedure can be standardized due to the versatility. It reduces operator risk, such as pulling out the sutures. Pre-suturing never needed, and you have a guide wire in place after the device has been withdrawn. That is maybe not disruptive. Many other devices have it, but not all. Thank you.
Anybody has a question from the...
Questions are, one, the patent is already done, I assume, because it's unique.
Yeah.
And for the closure device has become a commodity market. You are definitely having additional points compared to what's in the market. But if it's looked at as a business totally, what are the price point that the closure device will go into the market?
Well, you know, this company, I am the medical officer in the company. I know everything about fascia. I am an important part to develop the fascia. I think it would not be smart by me to, because this is business strategy, and that's a thing for the CEO and his closest team. So I don't think I should answer that question.
Okay. Let me ask you a question.
It's your company. It's just the way I'm looking at it, that if somebody wants to invest, if they're looking at the technology, there are a lot of people who may want to be a part of the company that's growing up.
Let
Price point should be around $200, not more.
No, but that isn't a sustainable model. But I won't get into that. That's
I
fine.
can make a comment. Good. We know what the competitors are. ProGlide is the market leader, has 85% of the market. And in average, for a large bore closer, they need 2.3. They need 2.3. We can also, in sometimes, need a second device, but say that we stay with 1.1. So we have a leverage because of that.
So my
So-
comment was about peripheral arterial, not Manta, not the large bore. So I might not be right about that. I don't know that price point.
Yeah.
But I know the one for Minx and everything else. All those are in the $200 range.
Okay. Does Dr. Amaya has part of this company?
Dr. Ramaya,
Now, the reason I don't need to know, but the reason is so important.
I think
I need to raise a different point, but I don't need. You
The
don't need to
concept.
disclose
What
it.
is interesting is always the concept of the technology, and that's what attracts me to technology is the concept. And this is an out-of-the-box thinking. Basically, you're not putting anything into the artery. You're using Prolene, and there's no plug, there's no nothing, and it's very unlikely that you'll actually damage the artery. But if you can get complete hemostasis, it's a game changer.
Yeah. So I was thinking a little bit different. An important point of ideas and intellectual property. It's a critical. As a scientist, usually we, when we have an idea, we love our idea and we like to discuss it with so many people. And before we obtain patent and secure that no one else, submit the patent before you share your idea or publish them with other people. Otherwise, you can lose the IP. So I think it's important when you have any ideas is to protect that idea. That's my point was in the beginning. So
Let
I
me
did
jump
not
in
know
there
if
for a
he
second.
took it from Dr. Amaya and form a company about it, or he formed a company with Dr. Amaya.
Let me jump in there for just a second. I have a conflict. I'm a co-founder, and I am the CEO of that company. So I will say we have, it's a good question about IP. We have 8 issued U.S. cases, an issued case in Europe, an issued case in Japan, an issued case in China, a pretty broad set of coverage, and about double that many on file. So it's a pretty solid IP portfolio.
Wonderful. Thank you so much. Is there anybody? Okay, great. We'll go to the next speaker then.